You're listening to All the Pieces, a podcast created to keep you informed. Now here's your host, Chief Quality Officer, Dr. Karan Mohan.
Hello and welcome to another episode of All the Pieces. I'm your host, Karan Mohan. May is Stroke Awareness Month, and stroke is one of those things where time is essential. Minutes equals brain time. And to discuss what strokes are and what interventions we can provide, I have very special guests with me, Dr. Chelsea Meyer and Dr. Almira, who have been a part of Mosaic's multidisciplinary stroke team. And before we get into the real meat of the matter, I would like everybody to introduce themselves and how long you've been here.
Yeah, I'm Dr. Chelsea Meyer. I'm a stroke neurologist and the stroke director at Mosaic, and I've been here for about 6 years. And then we have Dr.
Sure.
Amira.
I'm Abdallah Amire. I'm a neurologist, interventional neurologist, vascular and neurointensivist as well. I've been with Mosaic since end of August 2024, so I haven't finished the whole year.
All right.
It's been exciting since.
We're excited to have you here.
Yes.
Yeah, excited to have you, and welcome to the team. Welcome to Mosaic. So, stroke comes in different flavors, right? What type of strokes are there?
So when people talk about stroke, we're typically talking about ischemic stroke, which means a lack of blood flow to part of the brain or a clot to the brain. That makes up about 70% of strokes, but technically hemorrhagic strokes are also a thing. So if you have bleeding in your brain that's non-traumatic, then sometimes we call that a stroke as well, and that makes up about 30%.
Which one's more dangerous?
Hemorrhagic stroke is more life-threatening, but both can be very debilitating.
Correct. And Dr. Amir, in your experience, when does neurointerventionalists come into the picture?
So, I mean, when is a very critical question actually with our stroke patients. It's because sometimes, unfortunately, it's too late for even an intervention to be offered. And I'm sure we're going to discuss more about the urgency and the acuity of stroke patients and how they present. But when we see a clot visually on some pre-procedure imaging, when the patient arrives to the ER and we actually see some narrowing or a clot that's occluding, blocking a vessel, and we think that they've come in within the right time window, that's something that we can hopefully try to help them with, where we can go in with an intervention intravascularly and actually try to reach that clot or that narrowing and try to open it up for them.
You mentioned a window. What is that?
So when we say a window, it's a window of time where it starts from the last known well of the patient, whether it was witnessed by a family member or a friend that they were at their normal state of living, or the actual time, if it was witnessed, when they actually started experiencing the stroke symptoms. So that's when that window starts, and then it's from then until we actually meet them in the hospital. So that window depends. We rely on it really quite a lot because we rely on it when we're deciding are these patients candidates to give them some sort of clot busting or clot breaking medication, or actually take him for a procedure.
Okay, and so if they're outside the window, which I believe is roughly how many hours?
So for clot busting medicines, or T and K is what we use here, we want to get them within 4.5 hours from their last known well time. For clot retrieval, then we typically think of within a 24-hour window, but it depends on imaging. The main thing is when there's a clot, it's actively damaging the neurons, and so we want to get it before there is too much damage. If we give a T and K or that clot-busting medicine or pull out the clot and the damage is already done, then we put them at risk for bleeding, and we're not going to help them recover.
Might worsen.
So the key is to get them as early as possible so we can save as much of their brain tissue as possible.
So time is brain, Dr. Meyer. How much impact is happening by the minute?
So when somebody comes in for a stroke alert, we act as fast as we can to save as much brain as we can. We know that we're losing 1.9 million neurons per minute as the stroke is happening.
That's a lot.
It's a lot.
How many? This is a silly question. How many neurons are there in the brain?
About 86 billion.
Really?
Yeah.
So 1.9 million neurons are impacted every minute.
When somebody's having a stroke. And
Wow.
the sooner we can open up those blood vessels, either with medicine or thrombectomy, then the more likely they are going to have a functional recovery or get back to the way they were.
And it's as long as they're within the window.
If we see them outside of that window, then those medicines or the thrombectomy won't necessarily help and will likely make them worse. So we're limited. So the biggest thing is recognizing when somebody's having a stroke and getting them to the nearest hospital.
And the sooner you can provide treatment within that window, the better. because we've had studies that really try to push that window as much as possible.
Right.
The more you push the window, the less benefit you get out of whatever intervention you're providing, whether it's the TNK or a thrombectomy. Because sometimes you push it so much that at that point you're only saving them from, you're just sort of saving a life rather than reversing a disability.
Right.
So although we say window, we also have to be a little cognizant that that window also has sort of smaller windows within it, and the sooner you can catch a case or recognize a stroke and actually intervene on, the better the outcome will be. For someone who's having the same exact stroke but presents within the first hour, is going to do better than the same patient with the same type of stroke, same size of stroke, same location, but presents, say, 18 hours later.
Right.
So it's all about time. We're just going to be, a lot of the talk today is going to be about time, obviously.
Yeah. So and that's a good segue into my next question. How important is teamwork when it comes to say, hey, we have a stroke patient coming in? How does that process work?
Critical. So, even before a stroke patient comes in, the ambulance or EMS will call the ER and say, hey, we're having a stroke patient come in. So that way we can be ready on the scene right there. Then the ER physicians, the nursing, they're all going to evaluate the patient as quickly as they can, and we'll get them to a CAT scanner. We have to get a CAT scan before we can do anything else to figure out if we're dealing with a bleed or dealing with a clot. And
because you don't want to give clot busters on a bleed.
That would definitely make somebody worse.
Gotcha.
So once we get that CAT scan, then we can decide whether this person is a TNK candidate or not. And then we will get a CAT scan of their arteries to look at if there's a big clot. And if there's a big clot, then Dr. Amira might pull out the clot with the thrombectomy. So all of that needs to happen within 30 minutes, ideally. And Mosaic does a really good job of making that happen. The ER has worked really hard on making sure those times are as close as we can to giving it, and we get accredited based on those things. And right now we have an AHA stroke accreditation that's like Gold Plus Elite because we have become so efficient at managing these patients quickly.
Well, that's kudos well deserved for the whole team.
Yeah.
Because it is a time critical illness. Segueing into the thrombectomy part, how does that mechanism work? What is the actual technology used? Sure. Is there a big sort of scooper? How does it,
Sure. So it's an X-ray based procedure. So it's radiation there's radiation involved. We use catheters, so we access the arteries of the neck and the brain by either going through the wrist or through the groin, depending on each case. And then these catheters travel up to the neck. We take our pictures by really squirting contrast or the coloring dye through these vessels, and then we actually visualize where the blockage is. And then we try to go even further, inside the brain to reach that clot and mechanically retrieve it by more than one mean. We can either use just aspiration, meaning just sucking out the clot. Sometimes it's a resistant clot, so just sort of vacuuming it out doesn't work, and you have to actually sort of grapple on it by some sort of a stent that sort of pulls it out. So more than one technique, more than one device. Even science and innovation has gone a long, long way, even with the devices we're using. And every year we get a new device in the whole neuroendovascular world, not just for stroke patients, but every type of procedure we do, including stroke patients. So there's always innovation. If we look at 10 years ago, or 20 or 15 years ago, the type of devices we used for stroke, we would just laugh at ourselves kind of thing. And I'm sure in the future, 10 years from now, I'll be laughing at what I'm using now. Right. But it's just a continuously growing field in terms of devices being used and the innovation.
Smaller, thinner.
Yes, we're going, we've had, some blockages that are anatomically not accessible, for instance, in the past, or maybe, very struggling to get to, and then you have these new devices that actually allow you to not only get to it, but actually also get to it faster. Mm. And Mosaic has been great, where we've really worked with all the companies and vendors. We haven't held back on any device that we can get our hands on, and we've been able to work closely with all these vendors that are across the nation, and they've been assisting us with our cases, and it's been good.
So Dr. Amira, after a procedure like that, what does the recovery look like?
So all these patients get admitted to the neuro ICU, regardless of how well or ill they look. We just have to be watching them very closely. They usually get a nurse that is dedicated for them, that is not sort of sharing the care with another patient. They're frequently checked upon. The nurses are going in and out. believe it or not, at the beginning, it's almost every 15 minutes where they're just going in and making sure that they're still looking good. They spend at least one night in the ICU, depending, again, on how they look. And then the recovery, if it's immediate, then we start talking about going home. But some patients are not that fortunate, and then from ICU, they have to go to a less acute level of care. Some patients look good enough after that to go home. Some patients still need some rehabilitation, and we're extremely lucky here at Mosaic that we actually have sort of a unit within the hospital, an embedded unit of an acute rehab facility that's within the same facility, and they can go there for as long as needed. If it's just a few more days of acute rehabilitation, they'll get that. If it's a week or 2 or 3 weeks, they'll get that. So, it's not just that we're lucky that we're able to provide the acute level of care, but we're also able to provide whatever it takes for recovery. And I don't know if Dr. Meyer has been here longer than me, so I don't know how your experience has been with that.
No,
5 years. Yeah.
Mosaic's been great about really focusing on stroke. All the nurses have stroke training, so no matter what unit they're in, they have stroke training, ability to recognize it, and also able to educate patients, as well as, they'll see a neurologist while they're here, and then they'll meet all of the therapists. So they'll have physical, occupational, speech therapists, and when they go to acute rehab, if that's where they have to go afterwards, then they'll get 3 hours of therapy a day to really work on getting that function back, regardless of where they're starting at.
And of course, they follow up in our clinic too, as outpatient, depending on, their condition, if they need to see us sooner than later, or, depending on how each patient looks like. But every patient gets to also at least see us once in clinic. Because after the acute stroke, there's also a lot of work on focusing on, really after stroke, it's 2 things you focus on: how to recover and how to prevent it from happening again. And to prevent it from happening again, you have to understand why it happened in the first place. So a lot of attention is actually paid and focused on the workup of why that individual had a stroke. And sometimes that workup is completed while they're in the hospital, and sometimes that needs to be finished and still worked on as they continue to follow us in clinic.
And it's still very individualized care because everybody's
Absolutely.
Circumstances are a little bit different.
Absolutely,
And the
different
risk.
ages, different medical conditions, backgrounds that have sort of led to this event. Someone who has been heavily smoking since they were 18 might have a different looking stroke than someone who has lived a completely normal life, but then for whatever reason their heart just went into this abnormal rhythm, creating a clot, and then that clot just sort of flew up to the brain and blocking it. So we have to focus on, with the patient who is diabetic, high blood pressure, cholesterol, smoking, how do we manage all that to control it as much as we can, versus someone who has a cardiac issue that led to the stroke, how do we manage that with the assistance of our cardiology colleagues?
And everybody's stroke will look different. So some people might have very minimal deficits. You might see them and not realize that they had a stroke, and other people will be very apparent whenever you see them. And so depending on what their ability is after their stroke will determine what their needs are moving forward. So some people might go home with home health, where they have therapists coming to the house, or outpatient therapy. Some people might go to acute rehab. And we just have all of that available to us here, which is great. And the social workers and case managers will make sure that those needs are arranged and set up for them before they even leave the hospital. In general, it's great that Dr. Amira is here and this program has started. Before that, we didn't have thrombectomy, so patients would have to be transferred to Kansas City. So that's an hour or more sometimes to get them down there. And when we're talking about all those neurons lost, without Dr. Amira and the program here, our community didn't have that available as easily. So I appreciate that Mosaic has invested. I appreciate that Dr. Amira is here and really helping this community have better stroke care.
Yeah, an hour delay is 120 million neurons. Like that's, that's pretty significant.
It's pretty significant.
If you add them all up. Hopefully the bad neurons, not the good ones.
Yeah.
So Dr. Amira, speaking from a community perspective,
Yeah.
This is a much needed service, obviously. What have you seen since you've been here in the last few months? I believe on your first day you saw something. Is that right?
We, our first, building the service from sort of the ground up, it was actually a process that sort of started, I'm sure from an administration standpoint, and just discussing the idea of starting the service even started before I got introduced to Mosaic. But we have started building it 2 years before I actually started working physically here, even at Mosaic, because that involved building a whole new room for the what we call the angio suite, or the cath lab, where we do the procedures, choosing the right equipment, X-ray machines, devices, and even building a team of techs and nurses.
Right.
And so that was sort of a 2-year process until we actually started doing these cases. And we actually started doing some cases very selectively while we were finishing up the new room that was dedicated for stroke patients. We were still transferring patients out, but we wanted to try to at least start helping some selective patients when we can with what Mosaic had before this new equipment sort of was ready to use. And yes, the first case was actually, we were sort of thrown into the fire with it. It was actually a transfer from an outside facility. And we were actually supposed to do our last mock sort of trial out. We used to train on our own nurses and techs, moving everything, see how efficient and speedy we are. But then this patient arrived and everyone just looked at each other and we said, do we just do it? And I thought it was just perfect, right on time, where we said, you know what, let's just do it. And I think we did well. The nurses, the techs have been so invested in this. They really wanted to learn it. Since then, they have been functioning and performing so miraculously and just so great.
Yeah, talk about serendipity. It's a mock drill turned into a real life.
That was literally the case.
Yeah,
yes.
And for the betterment for the patient.
Yes.
It's really the right time at the right place with the right amount of individuals with the training waiting for them. So they definitely have somebody watching over them. What else would you like our community at large to know about the stroke program or signs of recognition or anything that would be beneficial to them?
I think it's important to know that strokes are incredibly common. So in the United States, every 40 seconds, somebody's going to have a stroke.
Wow.
So I think people don't think that they're going to know somebody with a stroke, but you probably do. And I think the biggest thing is recognizing when it's happening. So B, FAST, is kind of the acronym that people talk about. The B stands for balance, E for eyes, F for face, A for arm, S for speech, and then T for time. Those are just recognizing that when somebody has sudden change in their balance, their eyes are looking one way or not working correctly, they're having face drooping, arm weakness, something on one side of their body all of a sudden, then at least consider a stroke and bring them to the hospital right away. Like I said, we talked about this time window. Strokes don't usually happen with pain, so people don't even recognize that these symptoms are happening. So you as a family member or caregiver might notice something's different about somebody and need to bring them.
And it's happening in younger people too. It's not just, what we consider to be the classic, elderly person who's acting a little bit. I've seen it in younger people as well.
I've seen it in people in their 20s. Usually that's very specific cases, so that's not something I expect for everybody by any means. But you're right, it can happen at any age. And so if somebody has sudden weakness or something on one side, not the other of their body, then they need to be evaluated.
Yeah. And Dr. Beer, anything for the community?
I think it's all about just, let's give ourselves a chance of trying to get better in terms of, if a patient looks, unwell and all that. I think the education, knowing the signs, all that, that's where it all starts. Because if you're sort of neglecting, how something looks, your loved one or something like that, and then you're waiting for it to get better, then you're really reducing the chances. You're allowing more time to pass, reducing the chances of better outcome and recovery. So it's all about education. The community, the providers actually recognizing the signs of stroke and actually coming in as fast as they can. It continues to be a vicious disease, unfortunately, regardless of, yes, we have gone a long way. We have helped more and more patients as the year go by. But the fact is that still some patients, they still present and we do our best to help them, but unfortunately they don't do well.
Right.
We've had patients that have gone back to very much so just to complete normalcy. They just feel and look normal the following day. And we've had patients, unfortunately, that just did not look any different than when they came in. But you have to be as aggressive as you can be. You have to be as vigilant as you can be and treat every case like they're going to be the ones that are actually going to look so great the following day. And just give them all you can do and then hope for the best from there on after you've done everything you can, because there is still a 50% chance that they will go back to normal. Unfortunately, that doesn't apply to all patients, and we see it day in and day out. Some patients continue to worse regardless of how much we try. Some patients continue to do the same, and some patients go back to normal. But you got to give that chance to find out.
Everybody gets the same aggressive treatment.
Yep.
Yes.
And Mosaic is tremendously blessed to have that service provided here instead of going down south or anywhere else.
Right.
Well, there you have it, folks. Stroke or CVAs or TIAs or whatever you want to call them, is a vicious disease, and time is of the essence. Recognizing the symptoms and signs is essential, and getting them to the hospital so Dr. Mira and Dr. Meyer can do their magic and getting them back to normalcy. If you have any questions regarding this, there will be an article published with this podcast. Until next time, take care and brush your hair.